See this red light go on, bro? Because it's like professional. You're recording.
So, all right, guys. Like I said, this is going to be this quick, down and dirty advanced airway. Just kind of troubleshoot, giving you an algorithm of what things should look like when you're dealing with advanced airway. When we say the advanced airway, ET2, Gold Seal standard, that's what we're looking for inside the patient. And it's just going to give you a couple different ways to achieve that. So I like to start with a quick engaging video. The funny part is the lady just continuously laughing when she's doing it. So one of the things that I always look at when I'm going out to do an airway is preparation. So I'm looking for making sure my equipment's ready. We know we're going to capture an airway. You're going to have your laryngoscope. You're going to have suction. The biggest thing is people bring out suction, but it's not hooked up. Does that make sense? So you want to get it hooked up, turned on, make sure it can pull. And one of the ways I test it is I put it inside the glove, and if it sucks inside, then I'm good. I don't just put it up to my skin. I want to see that it actually's got some drawing power. Because remember, you're pulling chunks, fluids, all kinds of stuff through that. Pre-oxygenation is huge. If we're going to rapid sequence intubate the patient, it's not a rapid sequence lecture, but we're paralyzing, we want to make sure that we can make the chest rise and fall with a BVM. But oxygenating with a non-rebreather is also adequate. Just before you push a paralytic, make sure that you're using good BVM connected to O2. Positioning the patient's huge, and then obviously we know post-intubation, we're going to have placement with proof. As far as the post-intubation management, sometimes that includes just medicating the patient with that. So again, here's some pictures of your preparation stuff. Here's that picture of the suction like I was talking about. One of the things, if you have time, is to be able to look inside the person's mouth. Have you guys seen Melapani before? And how we actually grade airways? But if you assume that every emergency patient you're getting to is going to be a 3 or a 4, which is the assumption that we make all the time, that means that we're already planning for our first attempt or our first look to not go as well as we wanted to. Does that make sense? So we're already getting ready to go with an adjunct of some sort when we look at it. This is obviously the end goal. We're trying to look for that right there. So you just kind of imagine that it's a reverse way when you're looking at it with a laryngoscope. This is that looking through like a bronchoscope right there. And that's what the actual cords look like if we were able to pull them out of the neck for you to see there. We talked about pre-oxygenation. The biggest thing with your patient when you're going to do an advanced airway, if you're able to, is making sure they have as much O2 in their body as possible, so as much oxygen as possible, and less nitrogen. So we want to wash out all the nitrogen, and we want to put as much O2 in that space, and that's going to buy you time for your intubation. It's going to buy you time with a heart rate that's going to be good, and it's going to buy you time with a good oxygenation for it. All right. Once your patient goes unresponsive or you're bagging them, Selleck's maneuver. I know that if American Heart doesn't use Selleck's maneuver anymore, cricoid pressure, but in the world of critical care, in the world of emergency airways, we're still using it because we're assuming that the belly's full, and we don't want anything to come back up from that. So we're squeezing that esophagus down, bringing the glottis down enough to where we can actually squeeze the BVM and cause chest rise and fall. And with using the Selleck's maneuver and using a good squeeze, a good EC clamp technique, and getting that equal chest rise and fall, it's going to be one of those things that's going to buy you time. Remember, at the end of the day, it's about ventilation. It's not so much about what's actually in the airway, but can we make the chest rise and fall? Will actually calm you down while you're trying to get the airway in to the patient. So our first attempt went bad, or we looked in the mouth, and for some reason, we need to move on to something further. So before you see the gum bougie that's up there, before we go through that real quick, one of the two things that I'm going to do is I'm going to try to go with the laryngoscope and see if I can get a good look. If I'm not going to get a great look at the anatomy inside, then I switch to the camera. So we'll use like King Vision or some type of video laryngoscope. For me, for that to be ultimate, I gotta have a clean airway. So if it's a bloody airway, something that's gonna be nasty, then I'm gonna skip that step and go right to the step of the gum bougie. Has anybody ever seen this being used in real life? Have you guys used it in class at all? It's the cat's meow. It's like the new, you would think it's a new thing, but it's been around a million years in anesthesia. It's actually made for you to be able to almost blindly insert an ET tube into the trachea. The only thing you have to recognize is the epiglottis. I brought a couple real life pictures of a patient that we used it on. So this is us here on the day flight. We're about to actually intubate the patient with a gum bougie that's sitting up in the car. So it's kind of a hard intubation over the way here so you can see. So he's kind of going to be a hard intubation because he's sitting up, and I'm not going to be able to visualize a lot. So here's a closer picture, and you see how deep down he's in there. So I got the bougie and my ET tube in my hand and the laryngoscope. If I can get to the next slide. One second. There we go. Here's a closer view of it. So when you look at closer view, I see the epiglottis, and I'm using that curved tip to actually just follow through. And I think the last view is just them passing the tube through there. And you can see that I held the laryngoscope in there while I'm passing the ET tube, just so it doesn't mess up the anatomy part of it as we're going through there. Here's another thing that I kind of thought about, believe it or not, was actually my son clogged the toilet up, and I don't know how I came up with this, but I ended up coming up. So this is a meconium aspirator with a stylet going through there. One of the biggest things is that you've probably seen before is somebody's trying to intubate, clears the airway with a regular suction catheter, switches hands to grab the ET tube, and what happens? Airway fills back up. So I actually came up with this thing where I put the stylet through, the tape through there, and I'm hooking suction to the top of that right there, and an ET tube is sized for an 8.0 ET tube, and I can basically suction as I'm looking, and as soon as I see my cords, I'm just passing the tube through, and I'm not wasting time switching hands. So it's just another method of a bougie-like type product. Obviously, vomitus is our biggest enemy there, so if you can sneak up a gastric tube at some point through the process of intubation, that's something that we'll do a lot, just to keep the stuff coming out the tube versus filling in the mouth where we can't see what we're trying to work with. Our intubation fails, we got to move on to another device. One of the things I've been pretty lucky to do is work at places that we have an intubating LMA. So the LMA, as you can see in there, gets inserted real fast. We can ventilate the patient, and we'll ventilate them for a while, get them nice and stable, and then pass an endotracheal tube right through the middle of that. So it works pretty well, and and we've used that a couple times. Again, our end goal is trying to get that ET tube in the trachea. Here's just a regular LMA. So for whatever reason, the first LMA doesn't work, you can use this in the supraglottic airway. You'll notice that the one thing I'm not teaching you is a king tube, and it's just because in our world where I work out right now, king tubes just look to be very inefficient, and it causes a lot of bad side effects to the patient. So nothing against the king, but it's just what our experience is and what we use. Can't get the patient tube right now. No shame in using a bag valve mask, right? Bag them, as long as you're doing it right. Put an adjunct in there, like so, an OPA, and just let the chest rise and fall. That's what we're doing. Let the chest rise and fall. Look at what time factor we have. Is it going to be 20 minutes to the hospital or 5? If it's a 5-minute thing, I may just consider continuing to do that. Versus if it's going to be a 20-minute thing, then I can start trying to move, thinking of some other plans to do so. Let's say you get into a situation where you just can't ventilate, can't oxygenate. What situation is that? Surgical crack. So you guys are paramedics, in paramedic class. Okay, what's the age where I cut somebody's neck versus I put a needle in there? What do you think?
Size based on age based.
It's going to be age based. 12. 12 is the magical age. So 12, if you're specifically if you're taking like a state exam or PHTLS test, 12 is going to be the age you want to know for this situation right here. So once I get the ET tube in there, I want to confirm it. And these are some other stuff that's up there to confirm. But as far as like confirmation, waveform, exhale, CO2, number and a monitor with a waveform is gold standard. I can tell you that when we two people in the aircraft, we got the helmets on, we can't hear anything, that the way I know that the tube is in place is that we get a waveform. Sometimes the waveform may not be great, but it's a waveform. Does that make sense? And that's what we're looking for in that situation. We're going to document, you're going to do vital signs every 5 minutes. And again, if it's one of those patients where we use medications to intubate them, we're probably going to use like sedation, post, because those drugs that we use initially at the beginning wear off. So we use like a fentanyl versus sed mixture is our common one that we use. If it's going to be a prolonged transport or they're burning through their sedatives pretty fast, I'll give them like a rocuronium neuromuscular blocker. So I'll actually paralyze them so that my sedatives last a little bit longer. But you always sedate first, then paralyze. Never paralyze, then sedate. I think we got one more little video for you. I think it's always better to start funny and end funny, right? So like in between is doesn't matter. So that's it.